Let's jump into a deep dive on a symptom that's incredibly common, universally annoying, and surprisingly complex from a diagnostic point of view.
Oh,
Pruritus.
yes. Itching.
Or, as you probably know it, itching.
That inescapable sensation. And while it feels simple when you just want to scratch, understanding its roots is crucial, especially, for revising key clinical concepts.
Absolutely. This deep dive is specifically designed for you, focusing on extracting the most important info about pruritus, making it clear and high yield for revision, particularly if you're prepping for something like the MSRA.
Exactly. Pruritus forces you to think broadly, doesn't it, across different systems. It's often not just about the skin.
Right.
It's a signal the body sends when something else might be going on. Mastering the symptom is, well, it's fundamental for diagnosing a really wide range of conditions.
So unpack that for us. What exactly is pruritus at its core?
Fundamentally, pruritus is defined as an unpleasant sensation that triggers an intense desire to scratch the affected skin or even mucous membrane. The absolutely critical point here, and one to really underline for revision, is that it's a symptom.
A symptom, right, not a disease in itself.
Exactly, like a headache or a fever. It's pointing towards something underlying.
Got it.
And it can pop up acutely, come on suddenly, or persist as chronic pruritus, lasting for 6 weeks or even longer.
6 weeks is the marker for chronic.
That's the usual definition, yes. And either way, its impact on a person's quality of life can be, well, devastating sometimes, disrupting sleep, work, mental well-being.
I can totally imagine. Persistent, unshakable itch sounds awful. So, if it's a symptom, the next big question is, what could be causing it? What's the kind of breadth of etiology we need to consider?
Okay, this is where the deep dive gets interesting because the list is so broad. It links many different areas of medicine.
Right.
The causes fall into several main categories. Primary skin disorders are maybe the most obvious one.
Like eczema, psoriasis.
Exactly. But it extends far beyond that to systemic diseases affecting organs elsewhere in the body. You also have infections, allergies, reactions to medications you might be taking, hormonal imbalances, even neurological conditions affecting the nerves.
Neurological, wow.
Yes, and psychological factors like stress and even simple environmental triggers like dry air or certain fabrics.
Wow, that's a much wider net than just, say, dry skin or an insect bite.
Much wider.
It really reinforces why finding the underlying cause is the absolute priority for effective management, doesn't it?
Precisely. Just treating the itch symptomatically without identifying the root issue, well, it won't provide lasting relief, and you might delay diagnosing something quite serious.
So, given that vast list of potential causes, are there certain people or situations where we should have a higher suspicion for pruritus? Maybe for those less obvious causes, what are the key risk factors?
Yes, absolutely. Certain characteristics or existing conditions significantly increase a person's susceptibility. Think about people with atopic conditions first.
Atopic, so that's eczema, asthma, hay fever.
Exactly, that whole cluster. They have a predisposition to more sensitive or reactive skin, you could say.
That makes intuitive sense. Sensitive skin, tendency towards allergic reactions. Seems like a clear link.
Then, crucially, individuals with certain chronic medical conditions are at higher risk. High on this list are chronic liver disease and chronic kidney disease.
Okay, liver and kidney, key ones.
Definitely. Allergies themselves, obviously, increase the risk, as does exposure to known irritants or allergens, maybe in their environment or workplace.
Right.
Certain medications are notorious for causing itch as a side effect, too. Age is also a factor.
Older adults.
Yes, older adults frequently experience pruritus, sometimes just due to age-related skin changes like dryness, what used to be called senile pruritus. And, as you mentioned earlier, psychological factors. Significant stress or anxiety can either trigger itching or certainly make it worse.
So if you encounter a patient, perhaps older, with known kidney problems, and they report new onset generalized itch, alarm bells should start ringing. You're thinking, okay, this probably isn't just dry skin. Need to consider those systemic causes.
Exactly. Those risk factors help you build a profile and sort of guide your initial line of questioning and investigation.
Okay, let's peel back the layers a bit. What's actually happening biologically when we feel that intense, sometimes maddening urge to scratch? Can you give us a simplified picture of the pathophysiology?
Okay, think of the skin and nervous system as this complex communication network, always on alert. Itching is initiated by the activation of specific nerve fibers.
Itch nerves.
Itch-specific nerve fibers, yeah. They're distinct from pain fibers, though they can interact. These itch fibers are triggered by the release of various chemical messengers or mediators in the skin.
Like a chemical signal telling the nerves, itch here.
Precisely, and it's not just one signal. While histamine is the classic example, especially in things like hives or bites.
Right, antihistamines work for those.
They often do. But there are many other key players involved. Immune cells releasing substances, other mediators like opioids, serotonin, a whole host of cytokines as inflammatory messengers and things called neuropeptides.
Wow.
Even stress hormones can play a role, which links back to those psychological risk factors we mentioned.
Okay.
These mediators basically bind to specific receptors on the nerve fibers, and that sends the itch message traveling up the spinal cord to the brain.
So it's a really sophisticated system, multiple chemicals, multiple pathways.
Very much so.
And that explains why just taking an antihistamine doesn't always work for every type of itch, right? Because sometimes other mediators are the main drivers.
That's a key insight. It's definitely not a one-size-fits-all mechanism.
Which brings us to the crucial clinical challenge, the differential diagnoses. If a patient comes in complaining of itch, what's the comprehensive list running through a clinician's mind? What possibilities must we consider, especially for MSRA revision?
This is where knowing that breadth of causes is absolutely essential. We can broadly group them, maybe starting with the most obvious skin conditions.
The dermatological cause.
Exactly, and this list is long. Beyond common eczema and psoriasis, you need to think about parasitic infestations like scabies and lice.
Right, the creepy crawlies.
Then inflammatory conditions like contact dermatitis from an irritant or allergen urticaria, which is hives, lichen planus, lichen simplex chronicus.
That's the thickened skin from scratching.
Yes, exactly. Or Pruritus rosea, that distinctive Christmas tree pattern rash. Consider infections like dermatophytosis, which is fungal infections like ringworm, insect bites, or viral rashes. Don't forget conditions like dermatitis herpetiformis.
Leak-to-coeliac disease.
Often is, yes. Or even simple age-related dry skin senile pruritus or senile atrophy and heat rash, prickly heat. That's just scratching the surface of the skin causes.
That is a massive list right there, just for the skin.
Yeah. It is. But then you must consider the systemic diseases. As we said, chronic kidney disease causing uraemia and chronic liver disease causing cholestasis are really high yield.
Kidneys and liver again.
Always keep them in mind. Thyroid disorders, too, both overactive and underactive thyroid can cause itch.
So check TSH.
Got it.
Definitely worth checking. Then there are conditions like diabetes mellitus, so check HbA1c, certain hematological disorders like polycythemia vera, and importantly, some malignancies can present with itch.
Okay, systemic covered. What else?
Beyond systemic issues, consider allergies and drug reactions. Always take a good medication history. Think about neuropathic causes where nerve damage itself causes the itch sensation, like after shingles, post-herpetic neuralgia.
Nerve-related itch.
Yes, psychological conditions like anxiety, depression, or even delusional parasitosis.
Where someone believes they have bugs.
Exactly, when there's no evidence. And don't overlook simple environmental factors, dryness, heat, exposure to chemicals.
Okay, that's a really comprehensive framework. Skin, systemic, allergy drug, neuro, psycho, environmental. Phew. It covers most bases.
To make this concrete, let's think about a patient presentation. Imagine someone presents with intense, generalized itching. They say they feel okay otherwise, but you notice some faint reddish tracks on their skin, particularly between their fingers and on their wrists. Based on that picture, which differential diagnosis leaps immediately to mind from your list?
Okay, generalized itch, plus those specific red tracks, especially in classic locations like finger webs and wrists, sometimes described as burrows.
Burrows, yeah.
That pattern strongly points towards scabies, a contagious parasitic infestation. Needs specific treatment for the patient and their close contacts.
Perfect example of how location and associated signs can really help narrow down that huge list. So how common is this symptom overall? What does the epidemiology tell us?
Pruritus is extremely common. It's one of the most frequent skin-related complaints you'll see in primary care. Prevalence estimates vary, but it affects a significant chunk of the population at some point. It's definitely more prevalent in certain groups, notably older adults, and individuals with those chronic conditions we highlighted, chronic liver disease, kidney disease, severe atopic dermatitis. And yes, it does have an association with certain malignancies, although itch is usually not the only symptom in those cases.
Right, that link to malignancy is a key red flag to keep filed away, alongside other symptoms, presumably.
Absolutely.
Let's talk about what the patient actually experiences and what we might see. What are the key clinical features?
Well, the core feature is obviously the subjective itching sensation itself. Its intensity can range from just mild irritation to being utterly disabling.
Yeah.
It can be localized to one area or generalized all over. What you might see on examination could be the primary rash or lesion causing the itch, like the burrows and scabies or the plaques and psoriasis.
The source of the problem.
Sometimes,
Yeah.
but you will almost always see signs of the scratching, scratch marks, which we call excoriations.
So you see the consequence of the itch, not always the direct cause on the skin.
Exactly. You might also see redness, dry or flaky skin, scaling. If the itching has been chronic and severe, the skin can become thickened and leathery. That process is called lichenification.
Lichenification, okay.
And crucially, don't forget the non-physical impact, significant disruption to sleep, concentration, daily activities, and profound effects on mood and emotional well-being.
That sounds really tough.
Yeah.
This is where those specific symptom-based clues you mentioned earlier become absolutely invaluable, right?
Yeah.
Acting as high-yield memory hooks for revision. What are some of those key clues that can help point us towards a specific diagnosis?
Yes, pay close attention to when the itch is worse or what triggers it. If the itch is markedly worse at night, a nocturnal itch, this is a classic clue.
Okay, worse at night.
It could point towards systemic causes like uraemia from kidney failure or cholestasis from liver or biliary issues, or potentially psychogenic causes like stress or anxiety.
Nocturnal itch. Kidneys, liver, lined. Got it. Easy mnemonic.
Here's a really specific one. Severe itching that occurs shortly after a hot bath or shower.
Hot bath itch.
Yeah. That's a strong indicator, almost pathognomonic sometimes, for polycythemia vera, that blood disorder we mentioned. It's thought to be related to histamine release triggered by the heat change.
Wow, that's a very precise clue. Easy to remember, though.
Definitely one to keep in mind. If a patient describes the sensation of insects crawling on or under their skin when nothing is visible, formication, yes, or delusional parasitosis if it reaches that level of conviction, it can suggest a psychological condition or sometimes neurological issues too.
Okay.
A burning quality to the itch rather than just an irritating one can sometimes indicate neuropathic pain or more rarely be associated with lymphoma.
So burning itch could mean nerve issues or potentially something more serious like lymphoma.
Yes, important associations to consider. Now, the absolutely critical red flags to actively ask about and watch for alongside pruritus, associated fever, drenching night sweats, unexplained fatigue, or unintentional weight loss.
The classic B symptoms plus itch.
Exactly. Those symptoms together with itch should immediately raise suspicion for possible underlying malignancy, like lymphoma or certain leukemias. Urgent investigation needed.
Okay, so itch plus fever, sweat, stirredness, weight loss. Investigate for cancer. That's a crucial takeaway.
Definitely. And finally, a straightforward but high-yield one. If multiple family members or people in the same household suddenly develop itching around the same time.
Think contagious.
Contagious, exactly. Particularly scabies.
A mini epidemic of itch in the house. Okay, let's try another quick scenario using these clues. A middle-aged man presents reporting generalized itch. It's been present for several months. He denies any visible rash, but you see faint scratch marks. He mentions he's been feeling unusually tired lately and lost a bit of weight without trying. He also notes the itch seems worse when he's trying to sleep. Based on the clues you just shared, what combination of symptoms here raises particular concern and points you towards a diagnostic path?
Okay, so the combination of generalized itch, the fatigue, and the weight loss, coupled with the nocturnal element of the itch, that screams systemic cause.
Right.
Specifically, the weight loss and fatigue are strong red flags prompting investigation for potential malignancy. The nocturnal element also keeps uraemia and cholestasis on the differential list, which need different tests, but those red flags really guide the initial urgency.
Excellent. So history and exam are absolutely paramount for spotting those clues and guiding the next steps. Once we have a suspicion, what's the typical investigation pathway?
Well, investigations are entirely guided by your clinical suspicion based on that history and examination. However, there are some crucial first-line blood tests to consider when a patient has widespread itching, but no obvious primary skin disease on examination.
Okay, so no clear rash or infestation. What do I check first?
This is your initial screen for those systemic causes we've been talking about. You typically order a full blood count, FBC, looking for blood disorders, signs of infection, and ESR or CRP to check for inflammation. Serum ferritin, because iron deficiency anemia can sometimes cause itch.
Okay.
And crucially, liver function tests, LFTs, and renal function and electrolytes, urea and creatinine, specifically to screen for liver and kidney disease.
So FBC, ESR, ferritin, LFTs, renal function, the essential screen when the cause isn't obviously on the surface.
That's your baseline, exactly. Depending on the clinical context or if those initial tests show something abnormal, you might then add further tests. Things like thyroid function tests if you suspect thyroid issues.
TSH.
Yep. HbA1c for diabetes, maybe a bone profile, testing for HIV, hepatitis B, or hepatitis C if risk factors are present. Or even a chest x-ray if malignancy like lymphoma is a possibility, especially with those red flag symptoms.
Makes sense. And what about investigations directly on the skin?
Well, if there is a suspicious or unusual lesion, or the diagnosis isn't clear, a skin biopsy might be performed by a dermatologist.
Biopsy, okay.
Allergy testing, like skin prick tests or specific IgE blood tests, can be useful if allergies are strongly suspected as the trigger. Ultimately, if initial investigations are inconclusive and the cause remains elusive, referral to dermatology or another relevant specialist is often necessary.
So it's a structured approach. Start broad for systemic causes if the skin looks clear, then narrow down based on clues and initial results.
Right. Once we have a diagnosis, or maybe even while we're investigating, how do we manage this really distressing symptom? What are the treatment options?
Management really operates on two parallel tracks. The absolute priority is addressing and treating the underlying cause, whatever that might be.
Find and fix the root cause.
Exactly. Curing the infection, managing the kidney disease, removing the offending medication, and so on. But alongside that, you need to provide symptomatic relief for the itch itself.
Okay, root cause and symptom control. For symptomatic relief, there are some really vital general measures you can advise patients on. This includes trying very hard to avoid scratching.
Easier said than done.
Oh, absolutely. But it's essential to prevent complications. Keeping nails short helps minimize skin damage if they do scratch. Recommending light, loose cotton clothing, maintaining a cooler environment.
Avoid overheating.
Yes, and advising avoidance of hot baths or showers, harsh soaps or detergents, basically anything that could irritate the skin further.
Simple lifestyle changes that can make a big difference then. What about medications for the itch itself?
Pharmacological options usually start with frequent application of emollients, good moisturizers.
Moisturize, moisturize, moisturize.
Absolutely. Dry skin is such a common cause or exacerbating factor for itch, so hydrating the skin is fundamental. For specific issues like scabies, there are topical preparations like permethrin or malathion and maybe crotamiton for some soothing effect.
Right.
Oral antihistamines are particularly useful for itching, driven mainly by histamine release, like urticaria or insect bites.
The classic itchy culprits.
Yes, but they're often less effective for other types of itch, like the itch from kidney disease or liver disease, because histamine isn't the primary mediator there.
So oral antihistamines aren't a cure-all for every type of pruritus. That's a key point.
Not at all. For inflammatory skin conditions like eczema or psoriasis, topical corticosteroids are often needed to reduce the inflammation and thus the itch.
Steroid creams, yeah.
For itch specifically due to biliary obstruction causing cholestasis, a medication called oral cholestyramine is a classic treatment. It binds bile acid.
Okay, specific treatment there.
And then there are more potent or specific agents for severe, refractory, or neuropathic itch. Things like thalidomide, naltrexone, gabapentin, pregabalin. But these are generally reserved for complex cases, usually under specialist guidance.
Those sound like they target different pathways than just histamine.
They do, yes. Targeting nerve pathways or opioid receptors, for instance. Other modalities mentioned include UV light therapy, phototherapy for certain skin conditions, transcutaneous electrical nerve stimulation, or 10NS.
10NS machines.
Yes. Acupuncture is sometimes tried. And importantly, psychological strategies like habit reversal training to break the scratch cycle and cognitive behavioral therapy, CBT, especially when scratching has become a learned behavior or psychological factors are prominent. Research is also ongoing for even newer targeted therapies, reflecting how complex itch mechanisms are.
It truly is a multifaceted approach, isn't it?
Yeah.
Treat the cause, soothe the symptoms, support the patient psychologically, and with lifestyle changes.
So what's the typical prognosis for someone experiencing pruritus? Does it usually get better?
The prognosis is highly variable. It's directly tied to the underlying cause.
Depends on what's causing it.
Completely. The good news is that if the underlying condition can be effectively treated or cured, like clearing an infection, stopping an offending medication, or successfully managing a systemic disease, the pruritus will often significantly improve or resolve completely.
So treating the kidney failure should improve the uremic itch, for instance. Precisely. However, if the underlying cause is a chronic condition that can perhaps be managed but not cured, like chronic liver disease or some forms of severe eczema, then the pruritus might also become chronic, requiring long-term management strategies.
Right, ongoing management.
But generally, with an accurate diagnosis and good adherence to a tailored management plan, the prognosis for controlling or at least alleviating the itch is usually favorable.
That's somewhat reassuring. What are the potential downsides if pruritus isn't well managed? What complications can arise?
The complications primarily arise from the physical act of scratching. Relentless scratching damages the skin barrier.
Breaks the skin.
Exactly, making it vulnerable to secondary bacterial infections like impetigo from Staph aureus or even fungal infections. Chronic scratching can also lead to permanent skin changes like scarring and that pronounced lichenification we mentioned, that thickening and hardening of the skin.
Becomes like leather almost.
It can look and feel that way, yes.
Okay.
And we touched on the non-physical effects earlier.
Yes, the impact on life.
The psychosocial impact is huge and is really a significant complication in itself. Chronic, severe pruritus severely impairs quality of life. It leads to chronic sleep deprivation, difficulty concentrating, impacting work performance and social interactions, and it often causes significant psychological distress, including anxiety and depression.
It can become a vicious cycle, can't it? The itch causes stress. The stress then worsens the itch.
It absolutely can. A really debilitating cycle for some people. That's why prompt diagnosis and effective management aren't just about making someone comfortable. They're crucial to prevent these physical complications, break that cycle, and genuinely improve the patient's overall well-being and mental health.
Yeah.
It really underscores that while it seems like such a simple symptom on the surface, pruritus can have profound and wide-ranging consequences if it's ignored or poorly managed.
That was a really insightful deep dive into pruritus. We've covered everything from the basic definition and mechanisms to that huge list of causes, the crucial diagnostic clues and red flags, investigations, and the multi-pronged management approach. It really hammers home that itch is a symptom. Finding the root cause is absolutely non-negotiable, and effective care requires addressing both the underlying disease and the distressing sensation itself.
And it offers, I think, a powerful reminder of the interconnectedness of the body, how an issue in one system, maybe the liver or the blood, can manifest as a symptom entirely elsewhere, right there on the skin. It also highlights that often underappreciated link between physical sensations like itch and our psychological state, reminding us that managing symptoms sometimes requires looking well beyond purely physical interventions.
Really fascinating points to reflect on. Thank you. For more free MSRA revision resources, do visit freemsra.com. And for the full premium revision toolkit, head over to passthemsra.com.